Your seats. Welcome back, everyone. We are thrilled to continue our journey through the transformative landscape of digital technology with our first panel discussion of the day. This discussion is on bridging the gap, large language models as equalizers in healthcare and education for low-resource countries. Leading our distinguished panel is Shaukat Aga Khan. Shaukat is the Global Chief Information Officer at the Aga Khan University and Hospitals. A member of the senior leadership team, he is responsible for all ICT systems, serving over 20,000 users across AKU's global portfolio of hospitals, medical centers, and the university locations in Asia, Africa, and the United Kingdom. His career spans over 20 years, having previously worked at University of Central Asia, Novo Nordisk, UNICEF headquarters in Copenhagen. Today, we will engage our esteemed panelists through a discussion on how large models can serve as pivotal tools for equality in education and healthcare. Joining him are experts from the fields of technology and academia. Arshad Farhad from Dell, Klara from Harvard University, Ravi from the University of Michigan, and Ignacio, I hope I pronounced that right, from Siemens Healthineers. Ladies and gentlemen, let us give a warm welcome to Shaukat Aga Khan and our distinguished panelists to the stage.
Yeah.
Do you have a slide?
Yeah. Here. Good afternoon, everyone. I hope that you are all ready for another exciting panel. And I'm an accidental moderator today because our actual moderator, unfortunately, he has to go back from the airport due to some visa issues, so he was not able to come. But it's a real honor for me to be in this panel, especially two of my mentors and my inspiration as a CIOs are within the panel, and amazing experts from Dell and Siemens are here. And I have a personal touch with Siemens as well because I started my career with Siemens. So I have a lot of inspiring people, and I really hope that this discussion will lead to a lot of thought-provoking ideas for our future as well. So today we are going to discuss about bridging the gap, large language models as equalizer in healthcare and education for low middle income countries. And we have been hearing about LLMs from Ravi, about the AI from Klara, and also from Arshad and Khulud in the morning. So we are going to discuss some of those things in the perspective of Kenya and low middle income countries, because a lot of these amazing technological ideas, they are really, really good, but they are North America and in Europe and other parts of the world. But we just need to understand what is the context of these things in where we are operating, so that the policymakers here, the technology leaders here, they can get some inspiration and ideas and then start thinking about how to implement these models here. So I will just start with by requesting a very general question to all of you, maybe just in one minute or 2 minutes, you can talk about your initial thoughts on the LLMs and what are your initial ideas on as an advice to this audience and this country, that how they can start, because we all know that LLMs are there for helping us to remove all these language barriers, and we have seen the use cases and everything. But I think what is important for the audience is that where to start. And the audience, the companies and institutions who have already started, what are the next steps for them? So maybe you can start.
Well, thanks. Thanks, Shaukat. I would like to thank you, everyone, and express my gratitude for the possibility of being here today. This is very well appreciated. I have the chance to bring you a little bit the perspective of a large meta company, and I would like to give you a couple of facts and make it a small confession. First of all, we are Siemens Healthineers is a large company. We're embedded into the larger Siemens conglomerate, employing around 300,000 people. And we're present, our technology is present in pretty much every country of the world. So this is something that makes us proud, and it, of course, puts a lot of responsibility in the type of products that we bring to the market. When it comes to our install base, the number of systems we have around the world, we're approaching the 1 million systems operating in healthcare systems all around the world. These are CTs, MR, ultrasound devices, lab diagnostics devices, angiography systems, you name it. And the common characteristics they have is they are producing humongous amounts of data on a daily basis. Each and every of these almost 1 million systems, and I'm talking only for my company, are producing hundreds of thousands of examination-related data on a yearly basis. This is a huge opportunity, and I'm bringing the topic of partnering with industry. I think this is something really relevant, really close to my heart, and it's something I would like to encourage everyone to think of the industry, not of the new data colonization effort, but the opposite. We're trying to understand the challenges of other parts of the world, areas which maybe hasn't really attracted our attention initially, but they're very important. Do we have another minute?
We will discuss.
All right, so I'll leave it there.
So Ignacio works for Siemens as a head of scientific research for all the partnerships, almost for half the world, right? You cover Asia, Africa, and many other, and Europe as well. Yeah.
Yeah, thank you. I like simple and short, right? So I'll make it very simple, okay? And I think I mentioned I have a experience from running the hospital as a CIO, and now obviously providing the service to the hospital as well. So I understand the challenges from both sides, being in the industry for more than 20 years, right? So what I would say is, yes, large language model may sound a complex word and a complex setup, right? But this is not something you have to worry about. You're not going to build a model. I think Ravi mentioned into it. It's not something even Dell, we will not look into building a model. The model is already there, right? What you need to think about is the application of it. Which area you're going to use this large language model to make, either bringing clinical efficiency, either make non-clinical efficiency. So you come up with the use case. And in my experience, again, working in the whole region, I've seen organizations are more successful who start with more non-clinical use case, such as building efficiencies into non-clinical system. This is where you get the buying from your users, from your different departments. And one project is successful, then you will say it will grow, and grow. So don't be afraid of big word, large language model. You don't have to build it, you have to consume it. And this is where technology companies like Siemens, Dell, and many others are, as I said, are building a process of democratizing the solution. So you can, it's just like selecting something from a la carte menu and plug and play, use it into your setup.
Yeah. So Klara, thank you, Arshad. I think it's very interesting, and then we will come back with that. Klara, how is Harvard University actually leveraging large language models, especially in the education and healthcare? And if you can just contextualize that within low middle income countries.
Yeah, thank you for asking. You know, one of the things that people don't often appreciate is that United States is not uniform. So you can be in Boston, Massachusetts, and have this idea that there are many, many hospitals. And then you go to Western Massachusetts and you have problems with healthcare. That situation gets even worse when you go further out west. If you end up being in Native American reservations, et cetera, the problems are quite significant. So even though we often talk about countries as low, middle, and highly resourced, within a country such as the United States, you can have quite low resourced areas. And so that's, you know, where we are trying to just kind of think through how do we best impact that part of our communities. And what we have found is that oftentimes it's empowering the patients, right? So sometimes it's very difficult when you are in an area that does not have access to hospitals to actually get the care that you need. And so in our medical school, we have seen patients actually start investigating their own symptoms. Like remember, we used to joke about Dr. Google, right? And I have to admit, I have used Dr. Google before. But with large language models, it actually allows you to do more research and get more accurate answers. And the reason for that is because a lot of medical research is open. It's actually publicly available, and it is part of the large language models. And so we are quite excited, and there are risks here, don't take me wrong. But to the extent that we can empower people that are in lower resourced areas, whether it's lower resourced areas in different parts of the globe or even within well-resourced countries, to give patients more control, more power, so they can go back to their doctors with kind of more investigative ideas, is going to be really important. Because every single health system in the world that I know of is kind of splitting at the seams. There are too many patients, not enough doctors. There's not really a system where you have enough doctors and people can get care easily. Whether it's UK where you wait 5 hours for a check-in, or in the United States where it might be difficult to wait for a specialty. So in my view, the more empowered patients we have, the more prepared they are for their visits, the more equitable care we can get, not just across the globe, but also within countries.
Thank you, Klara. Just to continuing the subject, Ravi, you had made an amazing presentation, and you discussed a little bit of the large language models you're using at University of Michigan. So can you just share some specific examples within the domain of healthcare and education in the low resource settings from your perspective?
No, happy to. And to Clara's point, one may have impression that, okay, if it's US, everybody is well resourced, and that's not true. And it was very evident at the time of pandemic, the COVID-19, where, if you initially tracked the number of people who had died in Michigan, about 85 to 90% of them were dying in city of Detroit, in that area. And that population was mostly African-Americans because of challenges of resources and availability and so on. Also, during that time, some of you may remember this, people were asked to use pulse oximeters to measure your oxygen concentration levels. And you may know this, but because the way they're designed, the pulse oximeters, people who have my color skin, brown skin, or more darker skin, the pulse oximeters actually measured the oxygen concentration incorrectly. They measured it wrong because of the green light that's used, and it's easily absorbed by the skin pigmentation that I have, or my African-American friends have here, African friends. So as a result, it was measuring the oxygen concentration wrong. And it was actually found, a research paper was published by Michigan researchers after identifying that problem. Had that problem been understood earlier, potentially many lives could have been saved. So in general, the healthcare across the world is not accessible to everyone. And I believe that generative AI could serve as an equalizer. Some of our presenters talked about that. So there is a potential for leveraging this technology to as an equalizer. One example I can give you, and Klara talked about it a minute ago, that in emergency rooms across the United States, if you happen to go and have a problem, the wait times are really, really long. I experienced it myself in my amateur other life. I'm a photographer, not very good, but I'm still learning. And I had an accident and I fell and broke my hand and did a few other bad things on my hand, unfortunately, and had to end up in an emergency room and got, we had good doctors, they took care of me. But when the time came to give me discharge, and you talked about the discharge instructions, it took them 4 hours, more than 4 hours. And the instructions were, as I shared in my presentation, to go home, rest, take ibuprofen if there's too much pain, because I did not want to take oxycodone, which was also being prescribed. I didn't want it. And so when I said, I need to understand why it took 4 hours. And to your point, like Arshad pointed out, there are 3 or 4 disparate systems. And the poor nurse has to get information from this system, that system, that system, and collate it together. So what we have done at Michigan is leveraging the Maisie tool that I talked about. And you're absolutely right that we don't want to build a large language model, but we can build things on top of it. And kudos to your Chief Innovation Officer. I don't know if she's here, Farhad, where AKU is already leading in this space where they are actually using LangChain, which was also used at Michigan. So I offered her help. They're using LangChain on top of large language model to build a platform, which is the right way to go. And leveraging that platform now, we have deployed Maisie for that particular process. So actually getting instructions to nurse has gone down from what used to take many, many hours to a matter of minutes. Now it may still take the doctor 4 hours to sign that document because the doctors are overworked and busy, but hopefully in due time, we can improve that workflow. So that's one area I want to mention it. One other area I want to share that is not related to healthcare, but I think it's important for all of you to know is in US, there is a thing called Pell Grants. Pell Grants are given to students to go to college, and you can get that. So if you don't have resources, if you don't have money, you can actually get grants from the government to be able to go to Harvard, to go to Michigan, and so on. And $4 billion a year in Pell Grants go unused because some of these same kids that I talked about, sometimes they're from single family homes. They don't have parents who've gone to college. So they don't know how to fill out these forms. They don't know how to find this information. So Michigan is going to be releasing a public Maisie that will be available to anybody in the world or in US, which will have information about all the scholarships that are across the country that are available, that people can simply type in, I'm 17 years old, I'm interested in math, I'm female, I'm male, whatever the case might be. And it will find the 10 or 20 scholarships that you may be eligible for in a matter of few seconds. So as of last check, we have 17,000 scholarships that we have actually ingested from across the freely available sites across the country. And we hope to release it sometime in fall. We are working with financial aid experts to give us more guidance because financial aid is not my core competency or my teams. So there are all these types of opportunities. So even in Kenya, there may be scholarships available in part of East Africa. So you're only limited by your imagination in terms of what this technology can do. So take it on, leverage us as resources and change your world. You can do it.
Mm-hmm. Thank you. Thank you, Ravi. I will just come back to Ignacio. Siemens has been pioneering in technology innovation. Especially, we can talk about, you are in all sectors, but let's talk about health and education part of it. So how is Siemens innovating with large language models to create accessible and scalable solutions for healthcare and education part of it?
So thanks. Thanks for the question. Let me just give you a brief overview of the type of things we're doing when it comes to AI and large language models in Siemens. And maybe just give you a couple more numbers. The FDA started tracking the release of software medical devices recently, including AI components. There are about 600, probably 600 solutions on the market, which are FDA approved. And about 400, even more than 400 of them are from the radiology field, which we operate and have a big footprint in. So the areas we're basically trying to influence positively in this context are going in what we call the smart value or smart imaging value chain. This is the way we coin this term. So it comes from the moment where a patient is being referred to a modality, to an imaging modality or to a lab modality for a test. And we try to basically put together, and we train LLMs on this, put together the information available from the PACS systems, from the pathology devices, from the LIS system, from the laboratory information systems, from all sources of information from the company. Many of these informations are unstructured. So LLMs are really good at structuring text data. So we get all this consolidated and we make it available to the person who is actually performing the examination. We even have a prototype. I'm happy to show you if you're around, and I have my computer here. We have a little chat box, which is able to pull this information and offer it to the person at the right level of complexity required by the system and make suggestions on how the examination should be executed. Just another example, when it comes to executing the examination, we're training LLMs on clinical guidelines, and also on the system manuals of our devices. So the systems are able, or the LLM, the models are able to suggest how to optimize an examination for a specific clinical condition which has been brought in by the first element of this chain that I'm describing. And when it comes, once the examination has been executed, the post-processing of that data and the creation of the report in the clinical report, the medical report, can also be heavily automatized. We see gains here of about 50% gain in the first part, in the planning of the examination. We see gains in the execution of the examination of about 70%. So we're able to be 70% faster on how we examine the patients with these technologies. Now, can you imagine when it comes to capacity, what that means for countries with limited resources? Same applies for the post-processing side of things. You know, you're able to do much more complex evaluations of the data coming from these devices with less experience and in less time. So you have a double gain. Capacity and capability are compensated by some of the systems. And in the third and the fourth phase, you are communicating across departments, and LLMs can play a role at facilitating the communication with different departments in different jargons or languages that are specific. I mean, we are very familiarized with radiology language, but we know that oncologists have a different terminology. Maybe some of that can be adapted in the interdepartmental communication. And when it comes to communication with patients, we have ideas on how LLMs can support that, explaining patients' therapeutic options, for example, giving them also according to their maybe education levels or their socioeconomic context, to be able to make sure they understand the condition in which we are and the options they have and the possible consequences of taking one or the other path. So these are ideas which we believe are really exciting, that revolve around the type of technology we provide. And I come back to my first point. We are eager to partner with really relevant players like Aga Khan University to better understand the needs of your specific, your healthcare delivery specifics, and be able to come up with solutions that serve that purpose in the near time.
Excellent, thank you. Arshad, what strategies in Dell employing to ensure that the large language models in healthcare and education are ethically responsible and also culturally sensitive?
Great question. I think this is sort of question which comes up, I think, in each and every discussion that we have. When we talk about general AI, right? Can you hear me?
Yeah.
Even general AI. So, so there are two things we are doing in this area, right? So we have set up a large, so before I go into that, Dell have a large R&D arm. So we spend nearly $7 billion every year just on the R&D, which is like a 7% revenue that Dell have, right? And a very good portion of that goes into the security, and the second one goes into the ethical side of the AI that you have just touched on. So we have built a lot of partnership with organizations in different countries, because again, North America, Europe, then you have Middle East, then you have Latin. They have different requirements, they have different governance, they have different laws. So we have sort of localized the investment in sense of looking into the specific area of ethical and governance requirement, with the help from universities, with the help from healthcare organization, and building a framework. For example, in the EU side, we are working with European Union, the whole body, in terms of shaping what is going to be look like for the healthcare organizations in the next couple of years. The second thing, in terms of the simplicity, we are bringing more simplicity into how AI and Gen AI is going to be adopted. Right? From the R&D side, from the research side, we are making sure that the costly part of the solution, which are either the GPU, so how the GPU inferencing can be moved into more of the CPU, and how the ethical side is going to come into that as well. So in the future, near future, you will see the things which has been done in academia, we have the research about moving from GPU to CPU side, and all the ethical bias and all the security concerns are going to be shifting away into CPU cycle, which will make the adoption of AI and Gen AI more affordable, especially in the low-income countries and regions.
Yeah, very, very inspiring. So we will continue our discussions, and then I would like to ask Klara on the key challenges faced in implementing LLMs in low resource settings, and how can these challenges be overcome to ensure equitable access to healthcare and education?
Thank you for the question. You know, we already touched on it actually in, I think, most of the morning talks, which is one of the big issues with that we are facing is that all of these models are Eurocentric. It's actually amazing how much of the internet is written in English from either North American or European viewpoint. And so there's a lack of high quality data sets, and that could be high quality data sets in different languages. And I don't mean high quality, just the sheer volume that you need in order to train the model, right? And also with healthcare data. So when we are thinking about another issue, so first issue would be data scarcity. The second issue is that you can have a bias that can be introduced. If you develop a model, you train the model on a highly resourced country, and then you apply it to a low resourced country, you can have biases that are going to creep up where there are things that are just simply not going to be true in the other country. So it's the contextualization that becomes an issue. The other thing that's interesting is when you're thinking about low resource areas, there's often language diversity. So you have countries where people speak many languages. Ravi, I think you come from one of those countries, right? And so there's different languages, different contextualization in low resource countries, while United States is pretty much English speaking largely, right? So there's a complexity there as well. And then last but not least is accessibility, how to make it available. And you were already talking about computational resources and having scarcity of computational resources, but it's not just to develop the models, but to also run them, even the open source models. So the strategies, and I think this is like universities such as Aga Khan University or our program in Kenya can play an important role in partnering with communities in order to collect data and actually develop these high quality models on which the new solutions for low resource countries can be trained. And especially Aga Khan University, with running a hospital, could actually see how accurate those are. This collaboration with local communities is going to be very important. And this is a place where governments, NGO, universities will need to come together in order to make that work. We might also be able to do some level of model adaptation and using synthetic data to perhaps fill data that may not exist today. And last but not least, explore more of resource efficient models. So I was talking a little bit about the work by Professor Former, but the more we can make the language models efficient, so there are more and more studies that show that there are models that don't have to be large language models where you get the same level of accuracy with much less computational power. And in some ways, that is really the future. And it might be a way where countries, low resource countries, might be able to leapfrog, right? By you not just falling in love with LLMs, but there's a vastness of AI, and oftentimes even generative AI, the most powerful applications, are integrating them into workflow with other technologies, and which increases accuracy, et cetera. And that's where the opportunities truly lie.
Mm-hmm. Very enlightening. Ravi, based on your experience at the University of Michigan and other top institutions, how can academic institutions collaborate with industry partners like Dell and Siemens and others to actually accelerate and improve the healthcare and education outcomes in the LLM space?
No, I think it's going to definitely need all the players to work together, as was pointed out, because LLM by themselves, as I indicated in my talk, that one institution, no matter how many resources they have, doesn't have $100 billion sitting around to try to build these large language models. So what can you do on top of that? And so you will see a lot of products being rolled out by many companies, including the ones on this stage here. They essentially are using other technologies along with LLMs to try to come up with better models. Those of you who are physicians in this room or nurses, if you haven't seen this, check out a model that's available called Glass AI, GLASS, Glass AI. And what it does is based on the condition that you put in, it actually creates for you a clinical plan and a diagnostic plan. Clinical plan and diagnostic plan. So I have known of many resident doctors who are using it to kind of check their knowledge and check their analysis. And I've had many doctor friends check it out, and they have been very impressed with how accurate that is. Now, Glass AI has not built their own LLM. They have built it on top of existing LLM. So what did they actually do? Just like what AKU has been trying to do, they have leveraged tools like LangChain, which is open source. And on top of that, they're using a technology called RAG, R-A-G, or Retrieval Augmented Generation. Retrieval Augmented Generation. The Mazie at University of Michigan has been built on both LangChain and also RAG. And what RAG essentially does is it gives it a verified data store or a content store. So you're not saying, let my LLM lie. You're saying, okay, I want you to answer this question based on the data that I'm providing to you. Here is my content store, leverage it to answer the questions. So point I'm making is we have an opportunity here to do a lot of great work in this country, along with the Kenyan government and others across East Africa, where it was talked about how the models that currently exist are Eurocentric. What can you do about it? There is an interesting company in India that's currently doing something about it. It's a company called Klara, K-A-R-Y-A, K-A-R-Y-A. Klara, you might want to check them out. What they are doing is they're actually, you talked about languages. They're actually building a model in multiple languages, and leveraging local community to provide that data for them. And they're actually paying all of these people to do that. They're paying them $5 an hour. So somebody in the US could argue, you know, that's not a lot of money. How come you're only paying $5 an hour? What they're doing is to create the data set, they're having them read certain information, but the information that they're giving them to read includes lessons on financial literacy, lessons on hygiene, and lessons on many other things which improves their quality of life while getting paid. Some of you know this about me, that I grew up very poor in India when I was young. One time, for a mere 15 cents, our neighborhood grocery store made my mother put the rice we were buying back for 15 cents. And I still remember those days. My mother would have loved to have that $5. So before we judge everything with American standards, we need to think about this. So Klara is doing some great work. You might want to check them out. And models like that can exist here in Kenya and East Africa, because again, the language diversity that Klara talked about is plenty. So my challenge to you is approach this technology with what can you do as opposed to what it cannot do. It's very easy for human beings to get into this, oh, but I encourage you to leave that but behind and see what you can actually try to do with it. And maybe in due time, we find out this technology is useless. That's okay. You learn something new, but be sure to step up and do this, because build your language, build your data set, leverage that data set, work with industrial partners. Microsoft actually sponsoring all of the Klara's work in India. And by the way, I do not have any personal interest in Klara, if you're wondering.
Yeah, thank you, Ravi. Just to picking your brain on because we discussed a lot about data part, and I know that last time when I was visiting the University of Michigan, I was honored to be sitting in one of your meetings about the data governance part, and then you have a really amazing data governance framework. So just for the benefit of the audience, how you brought all those key stakeholders on the table that they are accepting and following their data governance policy. Can you talk a little bit about that?
I still have wounds to show how you brought everybody together. It is just like Harvard, Michigan has a very decentralized culture where sometimes as a CIO, I will make the rules, and then I'll go to my faculty office and ask the question, which idiot made that rule? As a joke, I'll say that to myself. But the point is, it's a decentralized culture, and it's tough to have these conversations. One of the first things, and data governance is a cumbersome process. It's a very detailed oriented process. It's not something that can happen overnight. It does take time. It does take a cultural change across organization. So one of the culture change we had to make at Michigan was remind everybody that it is not your data or my data. It's our data, not your data, my data, our data. That took a while. We also had to earn the trust of the community, because sometimes people will likely hand over their data to you if they can trust you. If they don't trust you, you're not, they'll say, well, wait a minute, what are you going to do with my data? So Michigan became the first institution in the country where we released publicly a student data dashboard called VisiBlue at Michigan that tells our students what data we collect on them, why we collect, how long we keep it, what do we do with it. And we are releasing one for faculty and staff this year now, same model base, because we're very transparent. So when I think about a data governance model overall data model for the institution, I envision it as a three-legged stool. One of the leg is the wisdom and the knowledge that we will derive from the data so we can make data-informed decisions. I do not use the word data-driven decisions. I make a distinction between the two. Data-informed involves human being always in the loop. Just like we talk about human AI, where human is always in the loop, with AI, with data decisions as well, human being must be in the loop, in my humble opinion. So that's why we want to make sure that one leg. The second leg is, of course, the data governance. You have to make sure your data governance is robust and not too bureaucratic. If it is very bureaucratic, where you expect people to jump through 20 hoops, it would have never worked at Michigan. So we needed our data governance to be agile enough, flexible enough, where it did not stifle the innovation and creativity of our faculty members. Because we often get requests for access to all types of data, including health data. Sometimes we have to say yes, sometimes we say no, but that yes and no has a process behind it. That process is really important, because what I've noticed is my amazing faculty colleagues, they are great if they understand the process and the process is transparent. If it is transparent, they are willing to work with you. And our answer often to them is not that it's no, it's what problem are you trying to solve? Let's work with you to get you to the point you need to go. The third leg is the security and privacy of that data. So data governance is one leg, can be too bureaucratic. Wisdom we derive is the second leg. The third leg is privacy, security, transparency of the data. And in my opinion, these three legs have to be in balance for your overall data ecosystem to work effectively, which is tied to AI and generative AI. Because remember, generative AI is nothing without the data. So that's why your data ecosystem has to be strong and robust and balanced. Because if you have too much security and privacy, then you don't have access to data. You can't do anything. If you have too much governance, people will try to, innovative people, human beings are absolutely genius. They will work around it. They'll work around your governance and get whatever they need to. Then you're reducing your security essentially, because people are going around Shaukat or going around Ravi or Klara and so on. So that's why these three legs have to be balanced. That's the approach we took. It took almost 4 years for that process. And all of that is publicly available on our website, the whole data governance process, the committees, the data stewards. When we started having conversations about data stewards, some people would say, well, but I don't want to be data stewards. And we had to tell them, no. Because by your role, you are going to be the data stewards. You don't get, it's not optional to you. If you're VP of HR, you are required to be a data steward for HR. And our VP of HR is great, and he partners with us and works very well. But you have to create a community around it. It's not a very sexy process. It's very detailed, boring process sometimes, but you have to get people energized about it, because by showing them the goal is, if you have this data ecosystem, then you can build Gen AI. If you have this data ecosystem, you can make life-changing decisions for the world. That's what you can try to do. So that's what we have tried to approach.
Thank you. Thank you. Very, very interesting. Klara, you want to add anything? Ignacio?
Maybe just one very quick comment. Is it on my microphone? Hello? Hello? Maybe just a quick comment from my perspective, because I was very much agreeing to what Ravi was saying from the industry. And we do work with a lot of partners in different countries. So that gives us the opportunity to look at governance models when it comes to data from different countries. And even though Europe is, I would say, and specifically Germany, the country I come from, the ultimate championship when it comes to the stringency of the way the general data protection regulation is implemented, I'd like to make one comment. Data is not to be protected. That's a misconception. And maybe before I make this comment, I would like to also agree with you on the topic of trust. This is the main common denominator to working with data in a partnership with academic partners. I come back to the point, data are not to be protected. The misuse of data has to be prevented. This is a very different type of game. So when we talk to CTOs very often, they are very into protecting the data, because they have this knowledge that the industry is going to come, is going to steal my data. I worked for this company for 20 years. I sleep very well at night. we have a really good reason to use the data, as you were saying. And I think this is a misconception that needs to be changed in society. And I will give you an anecdote. Germany has realized this is not sustainable anymore. And they started a radio campaign. I don't know how much radio you hear these days, but in Germany, people still listen to the radio because they drive a lot. And they were campaigning about making people understand how important it was for them to make their data available for science and for research. And this thought process is it's ongoing in Europe, and I welcome you to challenge the notion of protecting data and more to preventing the misuse of data. That was my point.
Thank you. Thank you. Yeah. Klara, how do you see the role of large language models evolving in shaping the future of medical research and healthcare delivery in low income setup?
So let me just say, we have already talked about it this morning. We have such fabulous panels, and Arshad challenged us already. The minute a baby is born, their DNA is read and they have personalized medicine from that point forward. Now that would be kind of a transformative way of using AI. But I think on a more simple, perhaps achievable, more easily achievable way, enhancing medical diagnosis. And, we are already talking about this here, right? How do we combine imaging data, clinical notes, labs, et cetera, to speed up diagnosis? And Ravi had a great example of bringing information to the nurses more quickly so they can make decisions more quickly. Perhaps a little bit further out, medical research acceleration, right? So we have medical research that often happens in well-resourced countries. Imagine combining it with some of the data that would be collected in lower resource countries to start asking questions. If something happens in Germany, for example, if there are certain types of outcomes in Germany and there are different outcomes somewhere else, why is it? What is happening? What are the underlying reasons for that? Then, an area where I think we are still struggling is just simply continuing education and healthcare worker training. Even in Massachusetts, I was mentioning the task force that Governor Haley put together. We are struggling with this area where people go from a clinical care to at-home care. And usually what happens is in clinical care, they're at the hospital, and at-home care is usually ran by different providers that are outsourced. How do you actually have the right level of information, diagnosis, access to information, and training that needs to happen? And of course, that can benefit lower resource areas as well. But last but not least, let's not forget about public health. And, I talked a little bit about what our students have done with malaria information. Well, generative AI can help have information more easily accessible, public health information in multiple languages extremely quickly. And as we learned during COVID-19, it is critical importance, especially since public health is often an underinvested field.
Thank you, Klara. And Arshad, you touched a couple of things in your presentation, but if you want to add anything on future, as we look towards the future, what are your predictions? Some of things you already mentioned, but for the next big breakthrough in the utilizing large language models to bridge the gap in healthcare and education in our settings.
If I just bet on one area, I think I would just use the word personalized. And this personalization is going to happen in healthcare, same in education as well. Personalization is there already, but the level we are trying to achieve using the technology, using different form of AI, like I'm generalizing the AI here, by the way, not just generative AI, different form of AI, the potential is huge. I think we are just touching the surfaces. And this is obviously the responsibility of technology company like Google, Dell, and others comes in to make it more democratized, make it simpler, easier. I normally give the example to our customers. If you go back, like those who have IT background, if you go back to the era when you used to type codes on the C language or basic language, then you had to remember everything. And then there was an era come, then you could just graphical interface. You can just drag and drop things and make your program work. I think this is something exactly what's going to happen to the AI world as well. You don't have to be a deep level programmer. You don't have to learn machine language. You don't have to learn a very deep information of low language model. I think this is something the responsibility for the Dell, for a technology company like us to make it more affordable, simpler, and to the point where you want to use it. So going back to the Klara's point, like the healthcare model has changed dramatically in the last few years, right? If you move back probably 3 years ago, just before pandemic, yes, the only place they used to get assistance or health check or any help was either hospitals or clinics or primary care, what you call it, right? But now the patient journey starts from home. And this is a challenge for CIOs like yourself and other leaders. How are you going to manage the data proliferation, which used to be in 4 or 5 places? For example, in the Aga Khan AKU, maybe you have 7 or 10 places, but now is going to be a million of places because every home is becoming a virtual hospital. The data is going to be generated with sensors, with IoT devices. So you have to make sure security, and the new trend which is coming in is to process the data, use AI at the point of generation rather than bringing. So this is obviously the federated learning, swarm learning. These are the technologies going to help us drive that as well. So one word, personalized, whether in the healthcare, or whether in the education.
You know, I would love to just continue this discussion for another 2 hours because there's so much learning from each one of you sitting with the CIO of University of Michigan, Howard University, CTO of Dell, and then head of scientific research from Siemens. There's so much we can learn, but because of the time, I have to conclude here by just saying that I have a profound sense of optimism after listening this for low middle income countries, that if we can do right, if we can think right, if we can have our right strategy with the right skills, then we can achieve equally good outcomes. So thank you very much for your enlightening talk and all the use cases you shared based on your experiences. Thank you very much.
Thanks for having me.
Thank you, Farhad.
Let's give them another round of applause. If I can ask Ignacio to hold on stage, we give him a little gift.
Thank you very much. Thank you.
From Shaukat.
Great job.
No, let me ask Shamira, you're here with us. If you can give the gift to Mr. Ignacio.